Malnutrition is one of the most devastating and pervasive threats to children in the developing world. It hinders both growth and mental development and contributes to more than 1/3 of all deaths of children less than 5 years of age worldwide. The tragedy of child malnutrition is that despite the existence of effective methods to prevent and treat it, many children continue to suffer. The best way to address malnutrition, of course, is to improve the economic well-being of families so that they have the resources to provide their children with proper nutrition. In the absence of such immediate economic growth, there are ways to reduce the toll exacted by malnutrition that couple economic development strategies with young child nutrition surveillance and intervention. The challenge lies in the fact that the places that most need such systems are also the places least likely to have the infrastructure to sustain them. Creating and running a young child nutrition program requires not only strong community support, but also substantial organizational, technical, and training capabilities. This video describes an effort to make young child nutrition programs significantly easier to start and maintain by incorporating new mobile technologies. It builds off of a system of locally trained community health workers, also known as health promoters, in Highland, Guatemala, who run a paper-based child nutrition surveillance program currently overseeing more than 1,500 children under the age of 5. They use World Health Organization growth charts that categorize enrolled children into 4 broad nutritional categories. Normal nutrition, approximately average or slightly above expected growth. Grade 1 or mild malnutrition, 1 standard deviation below expected growth. Grade 2 or moderate malnutrition, 2 standard deviations below expected growth. Grade 3 or severe malnutrition, 3 standard deviations below expected growth. Prior to the program's initiation in 2007, approximately 60% of enrolled children experienced moderate to severe malnutrition by 18 months of age. These rates are among the worst in the Western Hemisphere. Since the full implementation of the program in 2009, these numbers have significantly dropped. Life-threatening grade 3 malnutrition has been cut in half. Prior to the program, once a child fell into grade 3, they never recovered. However, with the program's focused family education and support, nutritional supplementation, and needed medical care, approximately 50 to 60% of all grade 3 children improved to grade 2 or higher over the first 6 months enrolled in the program. In addition, early preventative care reduced the number of children entering the grade 3 group in the first place. Despite these dramatic successes, it is clear that much more needs to be done. There remain too many children falling into grade 2 malnutrition while enrolled in the program. In addition, there are still some children in grade 3 that do not improve when receiving all elements of the current intervention program. Accordingly, the program is committed to creating and evaluating new, more effective approaches to preventing malnutrition in the first place and tailoring intervention protocols to meet the special needs of children who do not improve with standard intervention strategies. The introduction of new mobile technologies hopes to achieve this goal by streamlining the training, implementation, and monitoring requirements of the current paper system. In particular, this mobile initiative intends to reduce the training requirements for community health workers involved in programs designed to improve young child nutrition. The effort described in this video is a collaboration between the THOSH Rural Health Program in San Lucas Tolimán, Guatemala, the Stanford Computer Science Department, the Freeman Spogli Institute for International Studies, the Stanford Institute for Innovation in Developing Economies, and the Stanford University School of Medicine. There are 4 central objectives of the Young Child Nutrition Program, each of which must be addressed by the mobile initiative. The 4 objectives are to monitor all children under the age of 5 years, to identify those children at high risk of becoming seriously malnourished, to intervene with family support services, nutrition education, supplemental feeding, frequent home visiting, and increased growth monitoring. to collect and analyze data in order to improve the quality of the program, allow for optimal management of the program's supply chain, including the use of medications, supplemental foods, and finances, and permit collaborative evaluation and research activities. The mobile initiative has been developed to make each of these objectives easier to accomplish. The mobile initiative is centered on an Android application that will be piloted on mini tablets. There are plans to modify the application to allow use on smartphones. Health promoters will follow a specific workflow that guides them through the entire procedure of processing a child. The first step is to download the proper data. Due to a lack of reliable internet that is present in many developing regions, the application was developed to allow for offline use. Before working with patients, the health promoters must ensure that the necessary records are downloaded. As can be seen here, there are no records downloaded. The health promoter will be prompted to tap the download button and enter their unique username and password. This process will require internet. A successful login will list the various communities that can be downloaded. The health promoter simply selects which communities they will be working in and taps download. The records for all children living in these communities are now downloaded. The health promoter is now free to view, alter, and add new records, all without internet. The use of an online database that promoters can easily download data from will remove many logistical issues that come with a paper system. There will be no more worrying about records getting lost or damaged. Records can now be in multiple places at the same time, instead of being restricted to just one place with paper. There will be no need to constantly drive the records from the main town back to the communities. Now that the proper data is downloaded, a health promoter will want to identify a child. There are two ways to quickly find a child. The first option is by using the existing camera on the tablet as a QR code scanner. A QR code is an image that encodes information, such as an ID number. By tapping the QR code icon on the top bar, a health promoter will be taken to the scanning page. Each child in the program will be given an ID card that has a unique QR code. A health promoter simply needs to place the QR code in the view of the camera, and the application will find the matching child. With the tap of a button, the health promoter will be taken to the child's page. The child page will be covered in detail later in the video. The other option for finding a child is a simple navigation that begins by selecting which community the child lives in. This will bring you to the page for that community. Listed here are all the mothers in the community with children in the program. Being able to identify a child through the mother will speed up the process of quickly finding a child, since the health promoters generally know the mothers by name. Tapping on a mother row will display all their children in the program and the most vital information about each child: their current age, date of their most recent visit, and the World Health Organization grade for the child's weight for age and height for age. There are also symbols that indicate if the child has logged a visit recently and if the child is receiving supplementation. It is very easy to add a new family to the current community or add a new child to an existing family. There is a search option to quickly find a child or specific family, and filters to quickly identify certain subgroups. For example, health promoters can quickly narrow the results to all children who have not logged a visit for over a month, or to all children that fall into third-degree malnutrition in terms of weight for age. The ability to quickly find the records for a specific child is a vast improvement over sorting through a large pile of papers. Also, being able to identify subgroups of children is a completely new capability the promoters will now have. This will allow the health promoters to see how a community is doing as a whole and quickly identify those patients that are most in need of care. Once the child is found, a visit can be logged by tapping the Visit button.
The visit page will ask for the child's weight and height, along with various other questions related to breastfeeding, diet, and illness. When a child is first registered, various other questions will be asked as well. Where possible, we use drop-down options and restrict inputs to numbers to reduce the amount of typing needed. A new photo can also be taken, which will update the child's main picture. A health promoter can leave the form and all the information will be saved. This will allow for easy switching between different patients. Upon submission, the system will validate all the entries and alert the user if there is an error, such as a drastic change in weight from their previous visit that would be impossible. A successful submission will take the user to the child's page. There are two main components to this page. The graphs, which show the child's growth curve alongside various World Health Organization standards, and a recommended course of action for the child based off information from the most recent visit. Here, you can see the weight for age graph. The last point is for the weight that was just logged. The point lies just above the red line, representing third-degree malnutrition. This results in the child being flagged as in need of an intervention, which can be seen by the recommendation area, which is colored red when the child is shown to be at high risk and in need of an intervention. Tapping on this area will give a more detailed explanation of the type of intervention that is needed. For the THOSH program in Guatemala, weight for age is used as the indicator of if a child is in need of an intervention. If a child is less than 2 years of age and 2 or more standard deviations below the mean, an intervention is recommended. If a child is over 2 years of age and 2.5 or more standard deviations below the mean, an intervention is recommended. Interventions include social support, nutrition education, supplemental foods, and regular home visits. For extreme cases, a medical evaluation at the local clinic will be advised. These conditions and their resulting recommendations can be customized to suit the needs of different programs. Automatically plotting the child's growth curves and calculating their various grades of malnutrition will be a vast improvement over the current system in place.
With the current paper system, a large amount of training is needed to equip the health promoters with the knowledge and skill set to help these children. Most health promoters have a very low formal education and have never seen a graph before their training. This results in a large amount of time spent teaching the promoters how to plot these growth curves, as well as teaching them how to determine the proper course of action based on where the child's point lies on the graph. The new mobile technology will reduce these substantial barriers promoters face by automatically plotting the graphs based off the weight and height inputted.
By using decision support, the amount of training necessary to provide adequate care will be reduced, all while giving a more accurate and comprehensive recommended course of action. There are currently decision support algorithms being developed in partnership with this program that incorporate factors beyond simply the most current weight and height for a child. By looking at things such as previous weights and heights to get an idea of the child's trajectory, as well as other factors such as if the child has been ill recently, the month of the year, and even the presence of other young children in the household, we hope to better identify children at risk and intervene before the situation becomes dire. Once the health promoter is done with their visits, they will need to connect to the internet in order to upload any new records, as well as synchronize all the data stored locally to ensure it is current. All this is done through a simple tap of a button and the promoter successfully logging in. All communications between the tablet and the database on the cloud are encrypted. Also, we are using a mobile device management tool designed by Stanford that makes the local offline use of the tablet HIPAA compliant. A passcode on the tablet is enforced, and after a short period of inactivity, the tablet locks itself and encrypts all the data stored on the device. This tool also allows all the data on the tablet to be remotely wiped in case the tablet is stolen or lost. All the data will be viewable on a website that offers many management capabilities. Coordinators and supervisors with access to the website can view community-wide statistics, identify children flagged for in need of an intervention, review all data to ensure accuracy, track the use of supplemental foods and medications and ensure there is an adequate supply, monitor expenditures to ensure compliance with an approved budget.
The mobile initiative offers many advantages over the current paper system in place. Reduction in training requirements due to the ability of the application to automatically plot the child's growth trajectory. Decision support that better identifies children at high risk of becoming malnourished. Customizable recommended interventions dependent on the condition of the child. Data that is automatically viewable on a website with various filters available. Management capabilities to track supplies and finances. These advantages, along with many others, will assist programs such as the THOSH program in San Lucas Tolimán, Guatemala, in achieving their ultimate goal of improving health outcomes.